We're going to get started. I want to welcome everyone to tonight's webinar. I'm your host, Dr. Lauren Levine. Normally, I'd go straight into my introduction, but since these are special times, I just wanted to add a couple of notes first. First and foremost, I hope that everyone is staying healthy and safe. Secondly, I commend you for coming this evening and continuing your dental education. I know that many of you are either completely shut down or seeing emergencies only, but whether it's 2 weeks or 2 months or whatever, at some point, we're all going to be back to the full schedules, and education doesn't stop, and you've all proven that by being here tonight. And finally, and this is on a more personal level since IT is my area of expertise, in the interest of full disclosure, I apologize that we had to redo the registration link. The webinar registration was actually hacked yesterday. We had over 1,500 registrations that flooded in over a 2-minute period, all from Russia. We absolutely welcome people from all countries to participate in the webinar, and I'm sure Dr. Kosinski is very popular in Russia, but to have 1,500 people all register at the exact same moment was obviously a little suspicious. I had to shut it down immediately and make sure that everyone who wanted to be here tonight had a spot. And the point I'm trying to make is that if some of you are looking for ways to reduce your expenses until things recover, one area that I really don't recommend doing is stop from protecting your patient data. We've seen such a significant uptick in attacks over the past few weeks. There's a lot of bad people out there with a lot more free time on their hands that are going to try to make your life worse. So please reach out to your IT providers, make sure that they're still covering you. It's a great time to get all those HIPAA and cybersecurity projects that you've been blowing off for the last few months because you were too busy. Now you've got the time. As I said, when we come back, every office is going to be slammed once we recover with new patients, or patients returning to the practice. So you've got the time now that you may not have in the near future. So with that out of the way, I'm only going to speak for a couple more minutes. I want to make sure that Dr. Kosinski can speak for as long as he needs. He wants to take as many questions as possible. Many of you have been on these webinars in the past. You know how it works. You have a GoToWebinar control panel on your screen. Go ahead and type your questions as you think about them. We're going to try to get to as many of these at the end. It's extremely rare that we get to all of them. We have over 1,000 people registered tonight. Hundreds are still logging in right now, but we're going to do our best. In the next couple of days, you'll receive a couple things. You'll get an email to download a recording of the webinar. So I know sometimes people have other phone calls they need to take or have to handle their kids. Not a problem. We're recording the whole thing. During the webinar, Dr. Kosinski is going to be demonstrating a number of products that he uses, which are exclusive to GoldenDent. I wanted to thank GoldenDent for their sponsorship of this webinar. I've been thanking them for years. I especially thank them now because I think this is a critical time for offices to be able to continue education during this downtime. If you're a dentist or in the dental field, you know about GoldenDent and their commitment to dental education. And with that, it gives me great pleasure to once again introduce Tim Kosinski. Many of you have been on his previous webinars. He's an affiliated adjunct clinical professor at the University of Detroit Mercy School of Dentistry. He serves on the editorial review board of Reality, which is the information source for aesthetic dentistry. He's the past editor of the Michigan Academy of General Dentistry. He's also the associate editor of the AGD journals and was named editor of Implants Today recently, which is part of Dentistry Today. He's past president of the Michigan Academy of General Dentistry. If I read all of his stuff here, we're not going to be time for the webinar. So he's done it all. He's a member of OKU and Pierre Fouchard, University of Detroit's Alumni of the Year, received the AGD's Lifelong Learning and Service Recognition. He's placed probably close to 15,000 implants by now, published over 200 articles on the surgical and prosthetic phases of implant dentistry. He's contributed to textbooks like Principles and Practices of Implant Dentistry and Dental Implantation and Technology. And if you've ever seen Noble Biocare's Noble Vision, then you've seen his lectures as well. So Tim, pleasure as always to have you here. We're thrilled you can make it, and we look forward to tonight's presentation.
Well, thanks, Lauren. You always make me chuckle first thing in the morning. And I would also like to give my wishes that all of us out there are healthy and our families stay healthy, and we will once again be prosperous dentists. And I do also respect the colleagues for clocking in and spending an hour or so, hour and a half with us today to really elevate their career. And our opening slide here, our title is Predictable Suturing and Surgical Flap That Work. And this was a case sent to me by a dear colleague of mine in Pensacola, Florida. Shout out to Dr. Tilly. And she's training herself, and after one of the webinars, took that information and elevated her experience and is doing some exceptional work. So hopefully we'll motivate those of you out here who it's not an implant program, but more of a grafting program, and how to properly control tissue. I think will be a wonderful experience, and take this information and elevate your career to the highest level. Fly as high as you possibly can. So, Lauren, thank you. As most of you know, I practice outside of Detroit. University of Detroit is my dental school. I'm very proud of it. And most of the information that we're going to present here, of my work anyways, you can find on our educational website, drkosinski.com. So we have a lot of videos, a lot of technique videos and demonstrations that are also on YouTube. You can either get through drkosinski.com or through the GoldenDent website. So, when we put these topics together, we're trying to address the objectives of dentists out there. And one of the things that has become really popular is to learn predictable suturing techniques so that you get really, really healthy healing. As a general dentist, Lauren, thank you again for the nice compliment. We do place a lot of dental implants, and I challenge the general dentists out there to get involved, but to create the foundation for proper emergence profile and aesthetics. We must really have a good understanding of hard tissue or bone and soft tissue, and controlling that is very important. So grafting is a very, very important part of our daily practice, and we must understand how the healing process works. And suturing is very, very critical. Flap or reflection design is important to learn so that we can establish the best possible aesthetics for our patients. We'll briefly talk about different types of sutures out there, and suture needles, and we'll talk about which ones are resorbable and non-resorbable. We'll talk about different kind of knots. I know one of these times we did suturing alone. We didn't do so much of the bone grafting. We actually did suturing on oranges, so it's a great place to practice. And then we're going to talk about what I like to call atraumatic extractions. I know I'm criticized for that term a little bit, but minimally traumatic, trying to minimize the damage to the hard tissue when we're removing a tooth. And we all know, as general dentists, removing teeth can be very, very difficult and challenging. I know that because I see a lot of left root tips in the jaws. So let's learn techniques that make us more proficient and efficient. Let's try to minimally traumatize the hard tissue. Let's minimally traumatize our patients so that they can have a positive experience. And as important, let's protect our bodies. And so I'm going to show you the techniques that I use in my practice. There's 100 ways of doing all the things that we're going to talk about tonight, but I'm just going to show you the things that work really, really well for me, that make me successful. Here we are in beautiful Michigan. Up in northern Michigan, we still have snow, but it's still very, very pretty, and it's still very cold. So those of you in warmer weather, send it our way pretty soon, if you wouldn't mind. So these are some of the patients that have presented to my practice. We're in the suburbs of the city, and you would think, how can people possibly walk around like this? Well, there's a lot of reasons why people function or walk around like this. Maybe they had a bad experience in the dentist chair at one time in their life. Maybe there's financial restrictions. Maybe they're taking care of their family, their kids, and at some time of their life they realize that it's time for them to be treated properly. Obviously, dentistry has evolved to an incredibly high level. It's just a great time to be a dentist. Technology is improving so much, so quickly. And being able to provide high quality dentistry at a fair price to our patients really is the difference. Our patients are Google searching, missing teeth, teeth hurt, hate my partial, hate my denture. So there's a lot of information out there. So again, I think these online education programs from many sources are very important to again make us very proficient and financially rewarded during these times. So when we see patients like this, what does this mean? It means that there's an incredible potential for your practice, both professionally and financially. We must learn how to do extractions easily, atraumatically for our patients, so that is the best marketing strategy we can have. But we also have to realize that if we're removing teeth, we must build that hard tissue back up. We know that when teeth are lost, bone is going to shrink. It's going to shrink down and in the lower jaw, up and in the upper jaw. If we remove a posterior maxillary teeth, we know that the sinus floor is going to collapse. We know in the posterior mandible, if bone shrinks down and in, oftentimes it makes implants very challenging because of the position of the mandibular nerve and the mandibular canal. So hopefully will motivate you, for those of you who are not placing implants, surgically placing implants as a general practitioner, that we can set the foundation so that we can make you exceptional practitioners. There's a lot of programs out there that Kurt from GoldenDent will talk about. There's a lot of training on patients that we can help you really elevate your practice to an extremely high level. Lots of ways of extracting teeth. We all have a myriad of instruments in our practice. And I often say, why do we have so many instruments to take teeth out? Well, because it's hard, and we have problems, and we have challenges, and we talk to our friends, or we go to our exhibit halls and our meetings, and we find an instrument that we hope is going to be better. I'm going to focus on several instruments that I use just about every day in my practice, not for the last week or so, as we know, but for many years now that have I would not practice without. So we'll leave it at that. The instrument that I'm going to talk about is called the Physics Forceps from GoldenDent. Again, a Detroit-based company created by Dr. Richard Golden, just a brilliant man. It's a series of 4 instruments: upper right, upper anterior, upper left, and a lower universal forceps. You can see the little green covering. These are little silicone cushions for the instrument. And the instrument actually consists of 2 components. A beak, which is actually the working end of the instrument, and it's used to engage the lingual or palatal aspect of a tooth 1 to 3 millimeters subgingival. We must have a purchase point, and it is the working end of the instrument. The bumper is not the working end of the instrument. It is simply used as a center of rotation or a fulcrum, and it is placed as high up the vestibule as possible. And it allows us to rotate this instrument without ever squeezing the handles. We're creating leverage. We're creating a class 1 lever, creating tension on the palatal or lingual aspect of the tooth, creating energy. That energy is going to result in a physiologic reaction of the body to release an enzyme. That enzyme is going to break down the periodontal ligament. And what holds the tooth in place? The periodontal ligament. If the periodontal ligament is melted away by the tension created in the enzymatic release, the tooth will then be luxated up and out of the socket. The instrument's not intended to remove the tooth in total, rather than to luxate the tooth out of position. It allows me to maintain the facial plate of bone remarkably, and that's very important when we're talking about grafting and eventual implant placement, at least immediate implant placement. So it's just a wonderful instrument, again, that I would not work without. What's unique about it, and you can see my hand position, we do not squeeze the handle. We were trained to take a forceps and squeeze as hard as we can. And that creates tremendous energy, and that's where we end up breaking root tips and or crowns or the facial plate of bone in many situations. So I'm simply, actually my one index finger is what's creating the tension on the palatal aspect of this tooth. And I'm simply rotating, in this situation, towards the corner of the eye. allowing the tooth to luxate. It's not intended to remove the tooth in total, so we will take what we call a tooth delivery instrument or a bird beak forceps, and I'm able to simply remove the tooth very atraumatically with very little trauma to the patient. Oftentimes the patients will look at me and say, "You're done already? Really? Wow, I didn't feel that." Because they don't feel that tremendous force that we would use oftentimes with our more conventional extraction techniques. So let's get right into clinical demonstrations, bread and butter dentistry. A posterior maxillary teeth, let's remove it. So we have a tooth that's deemed non-restorable, and we want to remove this tooth. Now we know this tooth is 3-rooted. We know that the palatal root is the longest root in the mouth, but we also know that those teeth roots act like a tent pole holding up a circus tent. And if we remove the tent pole from a circus tent, what happens to that circus tent? It simply collapses. And in collapsing, the sinus floor will elongate, and it makes future placement of dental implants that much more challenging for us. So it's important that we graft these sites predictably. So here's the tooth, and I'm going to use my physics forceps. These are little periotomes from the GoldenDent kit, and you can see they're blue in color, which is I think they call it a plasma vapor deposit, which makes it a very, very strong and very, very scratch resistant, very high quality instrument. And I'll simply go around the outer edge of the tooth just to make sure I have proper anesthesia. And you can see the instrument going around the tooth and on the palatal aspect of that tooth. Then I'm going to take my physics forceps, the upper left, upper right, upper anterior, or lower universal. The bumpers are disposable. They're one-time use, and I'm simply using it as a cushion. Remember, the bumper is not the working end of the instrument. Rather, it is simply used as a center of rotation or a fulcrum point. The beak is serrated, and it will engage the palatal or lingual aspect of the tooth. We must have a purchase point. So if the tooth is rather elliptical in shape, what I would do is take a 557 surgical burr and flatten it so that we do have a purchase point. The bumper is simply slid into position, and you can see where the beak is engaging the palatal aspect of this tooth. The bumper is high up the vestibule as possible. I am not squeezing the instrument. I'm actually just taking the lower part of the handle and I'm elevating it towards in this situation, the left ear. I'm creating tension on the palatal aspect of this tooth, and in a matter of seconds, maybe 30 seconds, maybe a minute, the tooth will start to luxate. It'll pop. You're not going to hear it pop, but it'll disengage up and out of the socket, maintaining that facial plate of bone. As long as you're not squeezing and putting too much force on it, it is just a remarkable instrument. I like to call it magic oftentimes. I then take my tooth delivery instrument, and I'm able to remove this tooth in total, very atraumatically to the patient, atraumatically to the surrounding bone, and as importantly, atraumatic to my body because I'm not squeezing the instrument. I'm not creating a lot of energy. And you can see the divergence of this tooth. I did not have to section it, so it's very, very time saving. Now, I always take a radiograph to make sure that the tooth is removed in total. And the next step is we must curette. You must curette granulation. You must curette any purple blood in that area. It's very, very important that we scrape any infected tissue from that area. Now, oftentimes the question that we're going to have later is, what if we can't curette at all? Well, number one, it's important that you have an extraction kit. Again, GoldenDent, at the end of the program, I think has a really nice kit. You must have sharp instruments, and you're going to curette. Now, I will not immediately place an implant in a site that has an active infection. However, I can graft in that site, and I like to use the analogy of a hangnail. If any of you have had a hangnail on your toe, it can be extremely painful. You come home, you soak your foot, you snip it, and in 5 minutes you forgot that you even had a problem. The body's an amazing thing. When you eliminate the source of the infection, the body will heal very, very quickly and very well. So you can see I curetted and we're removing that big chunk of granulation tissue from the socket very efficiently and effectively. Red blood is great. Now this is a product, if I have all my walls intact, the facial wall is intact, this is just a remarkable product. It's called Osteogenic Plug. You can get it from GoldenDent, and I'm sure Kurt at the end will have a great deal for you. It is a bioactive calcium apatite material in a bovine Achilles tendon matrix. This material actually mimics the organic and inorganic components of physiologic bone, and the bovine Achilles tendon allows us to eliminate the need for a membrane. The bovine Achilles tendon will allow the epithelium to follow the path of least resistance, meaning epithelium will either go fight through this collagen matrix, or it'll go over the top. And because of the consistency, the epithelium will go over the top. Now, most of us know that when we use an allograft material bone from a human, we must protect it from invagination of epithelium, because epithelium basically grows 10 times faster than bone. A socket heals from the apex towards the crest. Epithelium grows from the crest towards the apex. And if epithelium grows significantly faster than bone, that's where our grafting procedures sometimes will fail. With this particular material, again, I would suggest that you use it where you have all the walls intact and you don't need a membrane with it. So it's a very, very simple, very inexpensive material that you can incorporate into your practice as soon as we get back to work. It makes socket preservation easy and affordable for the patient, and it gives us tremendous results. So here you see I took this this large plug and I cut it in the shape of the tooth that I removed, and I'm going to pack it into that socket site very slowly. You can see how the nice healthy red blood is absorbed into the material, and then I'm going to pack it firmly. This is not amalgam, we're not crushing it, but I'm packing it firmly to the crest of the ridge. Now this material is white in color. Obviously we have some initial bleeding into it, but eventually it'll be white in color, and I will always tell my patients that we put this material that's going to hold the sinus floor up, or it's going to prevent shrinkage of the natural bone, but it is white in color. I don't want them to think that it's an infection or pus. So I am going to place some sutures to hold it in place. And one of the simplest procedures that I'll use is simply an interrupted suture. But I'm going to slow down a little bit and explain the process. For those of us who have done grafting in the past, we've trained a lot of dentists over the years. Most of us, including myself at one time, we knew we had to suture it. So we would have a graft material, we would put a membrane properly, and then we would suture. Most of us would suture from facial to palatal or facial to lingual. But what happens in those situations is because we have a reverse cutting needle, we oftentimes would engage the membrane and suture the membrane down. But when we brought the patient back to remove the sutures, the membrane would come out. The membrane must be intact for at least 6 weeks if we're using a membrane or a barrier. If that membrane is dislodged before 6 weeks, the integration of the graft becomes unpredictable. And I don't want unpredictability. I want to know when I'm doing this procedures that we're going to get the result that I want in a very short amount of time. So what I'm going to ask you to do is to change your frame of thought and take this reverse cutting needle and engage from the crest to the facial. And now you can see with that reverse cutting needle, I'm actually sliding over my graft material in this position. And then I'm simply reversing the needle and I'm going from crestal or occlusal to the palatal aspect. Again, sliding over the top of my graft or sliding over the top of the membrane. And I simply have 2 interrupted sutures that will hold that membrane in place. Now, epithelium is going to grow 0.5 millimeter to 1 millimeter a day. I do not need primary closure. because the epithelium will grow very quickly over the top. In this situation, maybe we have, you know, 8-9 millimeters of exposed graft material. So it may take 8, 9, 10, up to 2 weeks for the epithelium to grow over the top completely. I will then allow this graft to integrate for 3 or 4 months. I will take a radiograph and we will be able to very objectively determine integration of the graft material radiographically, meaning we'll see changes in the radiographic consistency. Remember too, radiographically, physiologically, that bone will heal from the apex towards the crest. So you're going to see more healthy bone turnover at the apical portion over time, and eventually it will carry through to the crestal area. This is a wonderful suturing book, and the place where I know still has it is from Salvin Dental, S-A-L-V-I-N Dental. It's a schematic suturing book, very easy to understand. And as I said in the past, we've practiced on oranges. You know, now that everybody's home, grab some oranges or grapefruits, and it'll allow you to really elevate your suturing techniques to a high level. Lots of different types of sutures out there. My favorite is the PGA, or polyglycolic acid. It's a resorbable membrane. It goes by the brand name Vicryl or Villet. It's braided and it will resorb, but it could take up to 28 days to resorb completely. It resorbs to water, so we don't get a lot of wicking of bacteria and we don't get a lot of inflammation. Now, I mentioned earlier, I bring my patients back in a week to 10 days to remove sutures, even though this is a resorbable material. Silk is another very popular one. I don't use silk very often because it does have a tendency to result in inflammation and bacterial ingrowth. Plain gut or chromic gut is a very inexpensive suture. It's fine to use. Absolutely nothing wrong to use it. I just, as most dentists, we get comfortable with the materials that we use, and so I'm a PGA guy. All our needles today are reverse cutting needles, and we have different thread sides from 3/0 to 6/0, with 3/0 and 4/0 being the most popular in my practice. And I would recommend that you have 2 different sizes, radius of needles, a 3/8 circle and 1/2 circle. And again, when you talk to Kurt at the end, or if you're placing your order, he's going to be able to provide these materials for you very, very easily. So there's that, a lot of different packaging, resorbable, 3/0, 4/0, a suture of your choice. I just happen to like the PGA because the knots stay very firmly. It's very easy for me to use. It is resorbable, so if people are leaving town, sutures are not going to come loose. But I do like to bring my patients back and remove the sutures. Let's get back into some more clinical. Let's extract and graft for future implant a tooth that is deemed non-restorable. Now in this situation, I'll still use the physics forceps. I hope we all agree that this is a non-restorable tooth. When we have a 2-rooted molar tooth, this is where I do always section. I will section from facial to lingual, and basically what I want to have is 2 single-rooted bicuspid roots that will be easy to remove. Here, this is just a pointy burr that I use to go directly into the furcation of this root to see if maybe I want to place an immediate implant in that area. That's ideally where I would want to place this implant. I know this is not an implant training program, and Kurt, maybe we can do one of those in the future with Lauren. But I'm going to section the root so that now I have 2 simple bicuspid sized roots. I need a purchase point on the lingual aspect, and I will simply take my lower universal physics forceps and I will engage the lingual surface of this single rooted root and remove the teeth basically atraumatically. Here I'm using my Osteogenic plug again. I simply took a plug and cut it to make it look like the root of a tooth. I'm packing it into position, And again, I'm simply putting a couple interrupted sutures. Very simple, very predictable. Doctors, in 3 to 4 months, you will have an ideal site for an ideal placement of a dental implant. Immediately after grafting, you see the material has some radiopacity to it, but not total. But after 3 months, can you see the difference radiographically? We have bone ingrowth, we have osteoclast activity, osteoblastic activity, but more mature bone at the apical portion of the socket than towards the coronal portion. But that's okay. I can place an implant after 3 months because I'm going to remove that coronal portion anyways in my my osteotomy preparation. 3 months post-operative, we have a site that has good attached gingiva. I'm going to evaluate the band of attached gingiva in this situation by infiltrating, and now I can see the formation of the mucogingival line, the connection of mucosal tissue and attached tissue. And with all our implant cases, we must have a band of at least 2 millimeters of attached gingiva to be functional long term. Now I will simply go through my surgical techniques. I'm going to take an Orban knife, again in our surgical kit from GoldenDent, very high quality, and I'm making my incision on the lingual aspect of this crest, going around the facial aspect of the natural teeth, and I'm going to elevate with a periosteal elevator. This is a very, very precise reflection. I like to refer to this as an envelope reflection. If you take a number 10 envelope and lift the flap and blow into it, you can see I made no vertical incisions here. I made no vertical incisions here. As long as we're not incising into mucosa, our patients do not experience discomfort. Our patients do not experience discomfort. Once you incise into mucosa with vertical incisions, we will get tremendous prostaglandin and histamine release, and your patients will be very sore, they can bruise. So I try to maintain that reflection so that I have complete control of it without any vertical incisions. The lingual aspect here is still attached. I did not elevate this whatsoever. I'm then going to go through the process, and again, this is not an implant training program, but I think probably most of us understand. We start with a small burr to a wider burr to wider burr, and here we're simply threading our implant into position. When we're able to torque that implant to a certain degree, 25 Newton centimeters, I'm then going to place what we call a healing abutment. It's simply a tall screw that's threaded into the implant. Now, I said we must have a band of attached gingiva on a facial aspect of our implants. If we do not, this is a very, very important slide, and this is available on drkosinski.com and the GoldenDent website. I'm going to take my reverse cutting needle, the PGA material, and I went from mesiofacial through the mesiofacial tissue, but I'm not engaging the lingual tissue whatsoever. That lingual tissue is still attached. I'm going around my healing abutment. I'm reversing the needle and going from distal facial, not engaging the lingual tissue, and coming back around that healing abutment and tying a knot. So I've taken that attached gingiva that used to be on the lingual aspect of the crest, and I moved it to the facial aspect of my dental implant, which means I now have a bandwidth of exposed bone in this site. Doesn't matter. Epithelium is going to grow 0.5 millimeter to 1 millimeter a day. Patients do not experience discomfort. Patient came back in 1 week, and you can see how the tissue is already reorganizing. And I've taken that attached gingiva that was on the lingual aspect of the crest, and I moved it to the facial aspect of the implant. 3 months post-op, I'm ready to take my impression, evaluating the tissue, and we're able to get ideal emergence profile in a healthy implant site for our patients. Now, I did not fabricate this crown, the dental laboratory does, but again, we're trying to create emergence profile and a healthy functional tooth for our patients. Maxillary bicuspids. Here's 2 teeth that again are deemed non-restorable, and we're going to go through the same process of taking my physics forceps. Again, I would not practice without it. I call this an atraumatic extraction, placing the beak on the lingual, the palatal aspect of this tooth, putting the bumper as high up the vestibule as possible. I'm not luxating it. I'm not taking an elevator or a luxator. I'm not getting the tooth to move. I'm rotating my wrist towards the left ear, I guess, in this situation, creating tension, not squeezing the instrument, not squeezing, simply rotating, and the tooth will disengage, will pop. You're not going to hear it. It's going to disengage in a matter of seconds, and we're going to remove these teeth atraumatically. Now, you have to evaluate the facial plate of bone. If I don't have a facial plate of bone, we must repair it. So again, I'm going to take a radiograph to ensure that all the roots are gone. I'm going to take my Orban knife, and I'm going to make my envelope reflection, not making any vertical incisions so that I can see the defect. In this situation, I'm elevating the palatal aspect because it's a little bit different situation. I immediately placed my implants, and again, we're not training you how to place implants in this situation, but you can clearly see that we have no facial wall on the facial aspect of the implants, correct? So I have to repair this. And in these situations, I'm going to use the GoldenDent allograft material. Allograft material is human bone, cortical cancellous material, and it's also osteoconductive. We will wet it with sterile water or sterile saline. You'd never use anesthetic when you're using graft material. Anesthetic has pH of 2 and it will affect the healing. And then I'm going to use a membrane, again from GoldenDent, that will prevent invagination of epithelium into my allograft material. My dad was a carpenter, and he always told us to measure twick and then cut once. So it's very, very important that you understand that that membrane has to be specifically placed to protect your graft material. The membrane must be positioned at least 2 millimeters beyond any defect. So if I had a 6-7 millimeter defect here, I have to reflect that tissue enough so that I can passively place my membrane at least 2 millimeters beyond that defect. So the Goldos material is just a very, very high quality allograft material and very reasonably priced for both us and our patients. EpiGuide is a great graft material. It's a synthetic, it's resorbable, it maintains its structural integrity. And remember, I said at the very beginning of this program, we must protect our graft material from invagination of epithelium for at least 6 weeks. This will last six months. So obviously, it will protect our graft material wonderfully, and it's very, very easy to control. So you can see I measured my membrane, and I placed it passively beyond the defect that I created. You can see very passive. I'm not forcing it. I'm not tugging, pulling, ripping, tearing. It's very passive. That membrane becomes my new wall. And I'm taking my wetted allograft material and I'm simply packing it around the facial aspect. Doctors, if you follow this recipe, you will be able to grow a facial wall 100% of the time. But you must protect your graft material from epithelium invagination. That membrane must be intact for at least 6 weeks. So you want to use a high quality membrane to get the results that you want. Here's my graft material packed into position, and my membrane is passively placed along the crestal aspect to the palatal tissue. It's tucked in, it's passive, I'm not forcing anything. And again, the suturing technique that I demonstrated earlier, going from crest to facial, and then from crest to palatal. And these are just simple interrupted sutures. I'm not concerned that my membrane is exposed because epithelium will grow 0.5 millimeter to 1 millimeter a day quite predictably. You can see we will get nice healthy tissue. The laboratory will fabricate here, in this situation, custom abutments and some nice Bruxer aesthetic crowns. Oftentimes, we have to judge whether we want to do a flapless implant procedure or a reflected implant procedure. And I'm going to run through this relatively quickly. This is the same patient on contralateral sides. First, we have to decide if we have adequate room to place a dental implant. Again, our periapical radiographs often will distort the site. One way of measuring is to take a ball bearing of known diameter. Again, I would get this from Salvin Dental. It's a ball bearing of known diameter of 5 millimeters. And we can determine the amount of vertical height of available bone that we have to work with. We know the ball bearing is 5 millimeters. I use the Dexis, but I'm sure most systems now have some type of measuring device. And we can predictably measure the amount of vertical height we have to accept our implants. 16.7 millimeters, an exceptional amount of vertical space to place a dental implant. This eliminates the elongation or foreshortening that we would have from improper X-ray plate positioning. We can also measure the amount of tooth space. We're always thinking tooth up or tooth down. Implant position is important, but the final result, what your patients are seeing, are the aesthetics of the tooth. So ideal implant positions is very, very important to me. CBCT analysis is another way of determining the amount of available bone. CBCT is an excellent tool that makes us, again, more proficient and efficient and allow us to see things in the sagittal view or the facial to palatal view to determine the amount of available hard tissue that we have. Again, when we do an implant program, we can go through this again. We're evaluating the amount of attached gingiva. In my flapless procedure, I'm going to go right through the epithelium. If I'm not sure of the available bone or I want to see it, I'm going to do my envelope incision, as we said, and we're making that envelope. So we're not making vertical incisions into mucosa whatsoever, so we have complete control. And every implant system is basically the same. This is the Hahn system, where we have a 2.4 diameter pilot burr. We can determine our angulation positioning. We're thinking tooth up, so I'm looking at the emergence to idealize the position of that implant. And with a flapless procedure, I'm going to use a tissue punch to remove the epithelium from my osteotomy site. I'm going to widen the osteotomy with my osteotomy burrs. Again, I'm constantly taking radiographs to ensure proper angulation, emergence, and positioning. Widen the osteotomy. Again, take radiographs to ensure proper position and angulation, and I'm simply threading my high quality implant into place. We will then torque it. And because we were able to achieve at least 25 Newton centimeters of torque, I'm able to put a healing abutment. With a flapless procedure, you see how atraumatic the surgery is. We really are not traumatizing the tissue. When we reflect the tissue, I have to simply replace the reflection with sutures. And I will simply do 2 interrupted sutures to hold that tissue in position. We can see we end up with pretty good position of our implants. Let's just do a quick video demonstration of this. After we're finished, what we can do is we will remove those healing abutments. After about 4 months, we get a nice healthy tissue cuff in those areas. In either side, and you can see flapless or reflected, we get basically the same result. Here I'm scanning, we put our scanning pins in. I happen to use the Medit scanner, and we can send this information. It's really wonderful piece of equipment. It tells you when it's done. We send this to our dental laboratory, and I can have my zirconia crown in about 3 days. So pretty amazing technology that we're able to provide to our patients in a very, very short amount of time. The screw retain, and we'll simply cover those over with composite, and we can create function. Again, not an implant program, but I want to motivate you to our listening audience here that you are all capable of general dentists with proper education and techniques to really provide your patients some high quality dentistry. Immediate implant placement in the maxillary posterior. Really quick, again, another quick video. Very, very common situation. We're going to evaluate the site with our CBCT analysis, determining how much room we really have. I'm going to make my incision with my Orban knife, not incising into mucosa, making my envelope reflection. And again, same process with our implants. We start with a pilot burr, determining angulation positioning. We widen the osteotomy. We're placing our implants into position. We'll place our second implant parallel to the first, widening the osteotomy. If we have to do a sinus tent procedure, we have the ability to use osteotomes to lift the sinus floor precisely. And then suturing of this area, I just wanted to show you a different suturing technique. Because we have complete control of that reflection that we made, it makes suturing very, very easy. So this, I'm going to show you a mattress suture, which is very, very simple to use. I'm going from facial to palatal, and I'm going to tie my knot. Two forward. And I'm tying my initial knot. I'm just going to cut the tail now, and this will be called a mattress suture. So then I can continue about 1 millimeter, 2 millimeters apart from facial to palatal again, and then I'm going to go through the loop, just like tying a shoelace, through the loop. And this is one suture that is a very efficient, predictable way of suturing, very time saving. Facial to palatal again, through the rabbit ears. And I will just continue that in real time. So these procedures become very, very simple to do and very time saving for us to do. And when you get to the end, you won't go through the loop, and you'll use the loop as your tail. So these are really good suture techniques to practice, again, on an orange or a lemon or a grapefruit. And you can get really proficient at this in a very short amount of time. And we snip, and we dab it. And you can see, very, very simple suture because you had complete control of that reflection. You're not fighting it whatsoever, and our implant's in position. And our postoperative CBCT illustrates how we lifted the floor of the sinus quite efficiently. 1 week post-op, you can see how wonderful the tissue will heal with this PGA material, and we'll allow it to heal. Another situation where we have a lack of attached gingiva, I'm going to go a little quicker as we're running out of time. We have a very thin ridge. I'm going to make my incision on the lingual aspect of the crest so that I can reflect the area. I placed my implant. We let it heal. But then on uncovering it 3 months, I found, oh my gosh, I don't have a band of attached gingiva. I did a tissue punch, but I made a mistake here, didn't I? I am not in attached gingiva, or I'm in mucosal tissue. So I took my impression, but I have to repair this. Otherwise, the patient's going to have some periodontal issues and soreness. So again, I'm going to make an incision on the lingual aspect of the crest and reflect using my Orban knife. My implant is integrated at this point, so I can go ahead and put a healing abutment. And what am I going to do? I'm going to suture around that healing abutment. So I'm not engaging the lingual tissue whatsoever. I'm going around that healing abutment, reversing the needle and going around that healing abutment again and simply tying a knot. That bone is exposed at the crest. It will heal very quickly, doctors. 3 weeks post-op, when I'm ready to deliver the crown, you can see I clearly have a zone of attached gingiva here that I did not have 3 weeks ago. Nice tissue health. We place our nice screw retained implant crown and provide the patient some exceptional healing. Let's go to the anterior where we have a fractured tooth that is deemed non-restorable. We're going to use our periotome from GoldenDent. I'm going to use my physics forceps, never squeezing. I'm simply rotating my wrist, creating tension on the palatal aspect of this root towards the nose. And I'm able to very atraumatically remove this tooth without a problem. I'm going to reflect, and you can see I have a facial plate of bone, but doctors, you have to realize that the facial plate of bone in the premaxilla can be eggshell thin. So fracturing that plate is very easy. I just wanted to demonstrate with that physics forceps how we were able to maintain that facial plate. I want to elevate everything. I'm going to go ahead and place my dental implant into position. I'm going to torque it into correct position, put a cover screw. Here I'm going to use an allograft material from GoldenDent. I wetted it with sterile saline or sterile water. And again, I'm going to put my membrane where, doctors? It must expand beyond any defect, and it must be placed passively. So you have to feel comfortable making proper reflections in these situations. That becomes my wall, and I'm going to simply pack that area to plump out that facial plate of bone, that facial area, to create better emergence profile and better aesthetics for our patients. So the tooth will look more like a tooth. My membrane is passively placed from facial to palatal and docks. Again, the suturing techniques are very consistent from crest to facial, from crest to palatal. And tie your knots. And I'm going to do one more suture here to demonstrate. It's a horizontal mattress where I went from the mesial facial to the distal facial. And then I went from distal palatal to mesial palatal. And with one knot, I can just do my cross-stitched horizontal mattress suture to hold that area in place for aesthetics. And we will finish up here pretty much right on time. I know we're going to have a lot of questions, and I know that Kurt from GoldenDent, hopefully you got some good specials while people are sitting listening to us today.
I'm going to switch it over to the Kurt's screen. And just as I mentioned this briefly when we started, these webinars don't happen without the support and sponsorship of fantastic companies like GoldenDent. I mean, from finding the speakers to putting together the invitations and monitoring the webinar and the CE and the recording, we need help. And GoldenDent has been a partner of mine for many, many years. They bring great content to everyone out there. They always will have some type of great special as well. So yeah, we thank Kurt for being here. We're going to turn it over to his screen and have him say a few words, and then we'll get to the Q&A session.
All right, Lauren, I appreciate it. I apologize for coughing there for a second. Let me just get back to the beginning here. Okay, so I know a lot of doctors join our webinars on a regular basis, and if you're not familiar with GoldenDent, we're a Detroit-based company. We started with the physics forceps, and we've continued to expand and operate under the same thought process of providing simple, predictable, and unconventional dental products for a unique way to remove a crown or a unique way to extract a tooth, and different products like that I'll go over here just quickly. And so we rely on our 80+ years of family dental knowledge. We're a third generational family dental business here. First 2 generations were actually dentists, and then we're now in the third generation that's taken on more of the dental product and educational aspects of dentistry. So with the webinars, you know, I know it's interesting times right now, and I don't you know, want to avoid acknowledging that right now is you know, challenging times. A lot of dental offices are mandated with closures, but what we're going to do is I am going to still provide the 15% off coupon code if anybody wanted to take advantage of any of these specials. We normally do them for 24 hours, but I'm going to go ahead and extend this one for 2 weeks. And if there's something that was interesting this evening and sort of planted a seed for something in the future that you may be interested in, we're going to honor that through April 7th. April 7th here, which is 2 weeks from today. So we're going to do a 2-week deal instead of the normal 24-hour special we normally do on these webinars, just to try to be you know, realistic and more accommodating based on the situation with the virus here in the U.S. and around the world. So the physics forceps, this is was already explained in detail by Dr. Kosinski this evening. This is what started our company. This is the most popular set of instruments. This is what most doctors start out with if they are interested in learning more about the physics forceps, to see how they kind of function on their hands. We're actually, I guess that should say 13 years now. We started in 2007 with this product. And like I said, everything's kind of evolved since then. The next product we have here is our molar series. I don't recommend jumping into these maybe right away without trying the other instruments, which are the standard series. These are easier to use. You get better leverage. It's just simply a lever that you're pushing up or down, as was demonstrated on the webinar this evening. These get further back into the mouth and do get around the cheek restriction for hard to reach second molars and erupted third molars. However, you do lose a little bit of your leverage with this instrument, and it's sort of like turning like a round doorknob in slow motion. So it's a little bit more of a technique to use this instrument, where we find most customers pick up the technique with the standard series green bumper instruments quite quickly. These could take a little bit more practice just to get comfortable with them. I just want to mention a couple more products that we have here that were shown on the webinar this evening. These are your conventional type instruments. You know, if the physics forceps aren't for you, and you know, if a 150 or 151 works perfect for you, that, you know, that's great. We went ahead and made some conventional instruments that they look really nice. They have like a real nice aesthetic finish. It's a gunmetal finish, lightweight. They're not reflective. Have a great grip on them, and these are just your conventional instruments. And we tried to make these, you know, the best we could as far as the advancements that have been made in these conventional types of extraction forceps on the market today. The plugs, still a very popular product for us. I know this was demonstrated this evening. I won't spend too much time on this, but a great product. It's $212, it looks like, with the promotional code for a box. You get 5 in a box. I would say if you haven't tried them, the large is probably the more popular size. We probably sell 20 boxes to 1 slim. you can always cut it to shape, and the large is probably the most popular size, like I said, if you did want to try the Osteogenic plugs. Great product when you have all your walls intact, as was demonstrated on the webinar this evening. Allograft. So if you're not aware already, or if you're not already using our allograft, we do have a particulate and a putty form of the allograft. The pricing is very competitive. I know there's a lot of bone on the market, but it is a high quality graft material that we source from a reputable tissue bank that actually has some interesting processes that they follow, and it's definitely something to take a look at if you're using another brand. We'd love to have your business in the future for your grafting needs. EpiGuide, the one on the left is definitely our most popular. Dr. Kosinski has used this one for years. It's a big membrane. It's 18 by 30. It's large, so a lot of people do cut it in half. It's definitely going to cover more than one site. It's a fully synthetic membrane. It's probably our most popular. It's a long-lasting resorbable membrane. That's something that I would definitely take a look at. The CollaGuide's good too. I just think the handling is better with the EpiGuide versus the CollaGuide. So burrs, I know we talked a lot this evening about correcting the socket and how important that is. And this kit is a newer burr kit we have. If you haven't seen this or been to our website recently, these are great tissue and degranulation burrs. Actually, I need to get Dr. Kosinski one of these kits. He hasn't had a chance to try this one yet, but the two burrs on the top there are actually quite nice. They actually can go in and degranulate the socket site, where the manual curette can't quite get everywhere where you need to curette in the socket site, and then it just comes with two bone leveling burrs, a nice cutting burr, and then there's a good shaping burr too. So it's a simple kit for grafting, not too expensive. They're obviously multi-use burrs. This comes in the nice blue box that we made, and a good kit to have for your grafting needs. Suture, so we do have a PGA suture and a black silk suture. I know Dr. Kosinski uses the PGA polygalactic acid sutures more so than the black silk. I know he's not a huge fan of the black silk, but we do have both available. If anybody's on the webinar this evening has been waiting for the sutures on the top, those will hopefully be finally shipping this week. I know we had some orders of those in the last webinar. I know people are still waiting for them, so I apologize for that. Gel foam, this is an alternative to gel foam. This is BioViva. It's a great product that we have to control bleeding. I'm not sure if gel foam's still on a national back order, but this is an inexpensive product that's great for wound dressing, to control bleeding. Very effective product when you're not grafting the site. So I have a couple more slides here, and then we'll get into Q&A, so I apologize. I just wanted to mention this too. We launched a new line of mirrors, which I'm really excited about, at the Chicago Midwinter. And then obviously some things changed over the last month or so, obviously, in the industry. So I just wanted to mention these. Take a look at them in the future. We used to sell an air clean mirror called the Euro mirror in the past, and just one of the issues with it was it's a little bit challenging to hook up. And we found this new mirror system that we're really happy with. It has the ability to easily hook the air water syringe to the mirror, and it's inexpensive, which is also another great benefit. And so we really do like this system, and I recently just sourced this from Singapore, so I'm excited about this. There's some interesting mirrors. There's actually a suction mirror too, which has been popular with and some hygienists, and the air clean mirror is obviously great for like microsurgery and visibility. Something I'll bring up again, I guess, in future webinars, but I just wanted to point this out. It is new for us, and I thought I would do a disservice if I at least just didn't mention it. Again, now might not be the right time for this product, but I just wanted to mention it. Our matrix system, I've mentioned this probably 2 or 3 times now on the last webinars. If you joined in the past, I continue to mention it. It's been very successful. Doctors are very happy with the system. If you've currently using like a Triodent or Paladent type system, I think if you take a look at our ring, the interesting component on our system is actually that the ring is plastic. So it's more of a disposable type system, and the kit is super cheap. So it's a great alternative to like a Tuffmeyer or other sectional systems, or maybe if you're already using Paladent or Triodent or different types of bands. Our anatomical matrix bands are priced super competitive, and I think you probably won't notice any difference in the quality. So gross looking rings, I mean, rings can look like this after, this ring we took a picture after 10 days, has a lot of composite buildup on it. You don't have to worry about if they're still giving you that perfect separation. It allows you to modify the ring for a specific case. You don't have to worry about if it's actually thrown away. But the real big benefit is that you just get the perfect separation. So quickly, I'll just mention our hands-on courses. These are obviously sort of on hold right now. We have one coming up in May that hopefully happens. But these are the live patient extraction, grafting, immediate denture programs we do here at UAD and in Detroit. These are just some past course photos of the program. We do day one is all lecture, hands-on modeling, and then day two is live patient. So we see anywhere from 100 patients to 65 patients. Just depends on the program. You can learn more about them at Amplify, and hopefully we'll get back to it here. This was kind of a funny photo somebody sent me here just a couple days ago, and hopefully we'll be able to start working on patients again here at our programs, and you won't be using the physics forceps on dogs for practice here. So anyways, so I'll just mention this and I'll let Lauren get back to the Q&A thing. But again, it's good for 2 weeks and hopefully things turn here soon. And when it's the right time, we're here for you. And we appreciate everybody joining this evening. And now we'll get into Q&A, and the promo code is just HOPE15, trying to get a positive language in the promo code there. So it's just HOPE15. And I'll turn it back to Lauren.
Thank you, Kurt. Tim, you got time for some questions?
Absolutely, Lauren.
And I mentioned this at the beginning for those of you who may have shown up a little bit late. So a couple of housekeeping things. We did record the entire webinar. Golden Dental will normally send those out, usually within 24 to 48 hours. They are also providing CE credits if you were here live for the majority of the webinar. Occasionally we get people that come on for 2 minutes and then can't understand why they didn't get a CE form. We have no way of tracking if you are listening to this recorded, so it's only for the live. But and those usually take a few weeks, just because we had over 1,100 people registered and close to 700 that were on live at any one time. So give it time, but you will get all that information as well. We are going to finish at the bottom of the hour. We want to be respectful of everyone's time, including Dr. Kosinski. So we're not going to get to every question. I apologize about that ahead of time. We have about 25 minutes and close to 100 questions. So I'm going to try to combine a few of them as well. So it looks like there's some themes of some of the questions. So here's an interesting question. Tim, let's say you're doing an immediate implant where a bone graft is obviously indicated, but the patient, for whatever reason, says, I don't want to do the bone graft today. I want to come back in a week or two or three and do the bone graft. Is that even an option with the way that epithelium grows, or is it basically do it at the time or don't do it at all?
Well, that's a great question. The literature is pretty clear. If your gap between the outside of the implant and the facial plate of bone is 2 millimeters or less, the literature will say you don't really need a graft. Now, I routinely do it. I'll tell my patients when we remove a tooth, we create a socket that's shaped like an egg. Everybody understands that, and our implant is round, so we have a defect there. So I want to fill that defect with caulking material. Everybody understands that. One of the advantages, Lauren, that we have using the Osteogenic plug, and as Kurt alluded to, it's a very inexpensive material for us, and it works great. I've done a lot of histology. So if a patient doesn't want to do the graft right away, it's usually financial. But I think the most important thing is the end result. And our grafting procedures are simply creating a foundation for our final prosthetic design. So idealizing it is very, very important. Docs, the implants are the most financially rewarding things that we do. Grafting is just an adjunct to that. So if you can use a product that's relatively inexpensive, work it out with your patients. Do what's best for them. All that really matters is the end result. Okay.
What about you had, in a number of your cases, you showed some cases where there were black lines on the teeth. What were those for?
So for those football fans out there, and it's hard for us to say that here in Detroit, but a field goal kicker wants to kick the field goal right down the center. And we want to idealize the position of the implant to create emergence profile. And so I will take a Sharpie from Costco, they become disposable. And I will just draw lines on the teeth. I will draw a line where the mucogingival line is so that I can see it, and it allows me to see things in a different dimension to idealize the position of the implant. We can train you how to put every implant in ideally so that you get correct emergence. There's no reason to put those implants in improperly anymore.
Okay. Any thoughts about using PRF with your bone grafts?
Absolutely. We do that all the time. That's something that we draw and splin, and it'll just increase the healing. We have the growth factors available, and it allows us to get a faster response. So we'll use PRP, PRF with our allograft material. We'll use it as a membrane. Also, excellent okay. Tool for us to use.
In certain areas of the mouth, it's difficult to get primary closure. So what are your, do you have any major concerns if that's not achievable depending on, the specific situation?
No, because I'm using a high quality membrane that's I know is going to last at least 6 weeks. And the epithelium will grow over the top of it. Lauren, that's a really important question, because many of us have done grafting and then you go back and it's mush. It's not healthy at all. And that's because the graft was not protected from epithelium. I do not need primary closure. The resorbable membranes that we use today are high quality and last a long time.
Okay. You showed the mattress suture, and you showed a few cases of that. What are the indications? When would you use that versus another type of suturing technique?
Well, the most conventional one is an interrupted, but you use a lot of suture in an interrupted, and it's also very time consuming. So I love using a mattress because it's so fast, and it gives me a really, really nice result. And again, I think the challenge is to become proficient with different techniques. And that book that I showed you, the Suturing Book, is a really good asset because it's very schematic, and you can literally take an hour at lunchtime and practice on an orange and have the different techniques down pat pretty quickly.
Okay. Curetting, any concerns when you're dealing with upper molars and you've got a sinus that's obviously pretty close to that area?
Well, you're always concerned. That's what our concern is. We're concerned about the sinus, and we're concerned about the mandibular nerve. I think it's imperative that you get the granulation out. So sharp instruments are very, very important. If you have dull instruments or instruments that you've had since dental school, you're going to have a tendency to want to put more force there. Nature creates pretty healthy situations for us. So just curette the best you can. Again, I don't put implants in immediately in infected areas, but I can graft because the body will heal. Once the source of the infection is gone, the body heals pretty quickly.
Okay. The osteogen plug, what's in it? Is there any formaldehyde in it?
No, it's calcium apatite in a bovine Achilles tendon matrix. It's been used in Europe for 40 years. Done a lot of histology on it. And we get really good bone growth in a very short amount of time.
And how long does it typically last before it's going to resorb?
3 to 4 months, and you can determine it radiographically. You can actually see it change over radiographically.
When you're sectioning a tooth, do you have a favorite burr that you like to use?
Just a 557 surgical burr, pretty standard.
Okay. Okay, let's see if I'm going to read this question. With a thin biotype, if doing an atraumatic extraction, how are you able to suture after grafting since it's difficult to approximate the tissue?
So when you say thin biotype, that usually means mucosa, and and because when teeth are lost, physiologically bone's going to shrink. It's going to shrink up and in, and it's going to pull the mucosa with it. So, obviously you have to be concerned with it. You're gentle with your tying your knots. Maybe use a smaller needle diameter, a smaller thread size, and be careful with it, but I don't need primary closure. I don't need to pull those tissues really taut to each other.
Okay. You talked about, I think in one of your early cases, you were talking about using a binder. What do you use as a binder?
The allograft is a particulate, and it's dry. It's like sand almost, and so you want to wet it so that I can control it easier, so I can carry it to the site. So I just wet it with either sterile water or sterile saline. Never anesthetic.
What about using something like, okay, so like Lincocin or antibiotic or something else to rehydrate?
That's come and gone in dentistry for many years. I just haven't done that, and I've gotten tremendous results without using any tetracycline or anything like that in it. I don't have any issues, and I don't need to mix it with antibiotic.
Okay.
That's me.
Let's say you do get an exposed membrane. Are there any specific post-op instructions that you're going to give to the patients at that point?
I'm not concerned if it's exposed. I just want it to remain intact. So the surgical protocol is very, very important, the recipe, so to speak. That membrane has to be placed beyond, at least 2 millimeters beyond the defect, and it has to be passively placed from facial to palatal or facial to lingual. And once it's established, it's not going to come out. The problem that we have is that we have a tendency to want to tuck it and not really have it rest passively, and so it dislodges. And if it dislodges before 6 weeks, the case becomes unpredictable. I didn't say it won't work, it just becomes unpredictable.
Okay. Just trying to get as many of these as we can. What would you do if a patient returns after a few days and the membrane popped out? Do you go back in and place a new membrane?
Yeah, I would re-incise, and yeah, but otherwise, because then it becomes unpredictable, I would probably curette it and just start over.
Okay. How does a particulate allograft compare with porcine scaffold material when used with membrane to repair the buccal defect? Do you have a preference?
I will use the literature now. You know, dentistry is really funny. If I have a facial wall missing, I will use allograft with a membrane. If I have all walls intact, I will use the Osteogen plug almost exclusively. You can use the Osteogen plug with a facial defect, but you must use a membrane on top of it to protect it. I'm not familiar with the porcine material, and I don't use bovine. I don't use cow bone either. I haven't had good results with that with our going back and placing implants later. That's just me.
Okay. We talked about the black lines. Hold on, I'm just trying to get to as many of these as we can. On the maxillary bicuspid case where you grafted over the implants, will you have to cut through bone to uncover the implants?
No. The implant is slightly supracrestal. I didn't place it. The bone won't go over the top of that cover screw. Once in a while it will, but normally not.
In one of your previous lectures, you had mentioned sometimes you'd like to inject like 4 milligrams of dexamethasone to reduce post-op inflammation and pain. Do you still do this in a site where you have grafted and placed a membrane?
Absolutely. If I incise the patient, I will inject 4 milligrams or 1 cc of dexamethasone phosphate to the site. Yeah.
And can you just remind people why you don't use anesthetic? Is it because of the pH of it for the wetting material?
When using an allograft, you don't want to mix, because our anesthetic is pH 2, and it inhibits the osteoclastic activity. So the predictability of the graft integrating properly or as quickly as we'd want it to is decreased.
Okay. I don't think you show a lot of cases with pero dressing, like the co-pero dressing. Do people not use those anymore?
No, I haven't used that since dental school. It's just amazing. Those patients do not experience discomfort, and you have to remember that physiologically, epithelium is going to grow 0.5 millimeter to 1 millimeter a day. So within 3-4 days, it completely covered over.
Okay. Let's see. Can we use the Osteogen plug with a membrane when we've lost the buccal plate during extraction or socket preservation?
Yes.
With physics forceps, I often find that patients experience a large canker in the vestibule. Is that normal? Which I know it's not, but often they complain more about that than the discomfort of the extraction itself. So, what typically would you recommend if people are seeing that type of situation?
Lauren, that's technique. It's because our muscle memory to do an extraction, we want to squeeze, and we're putting tremendous force. And so if you're getting excessive ulceration or whatever, it's because you're squeezing it and you're trying to use it like a regular forceps. So it's really rotation of the wrist. It's not squeezing of the instrument. The bumper is simply a center of rotation. It is not holding anything in place. It's not holding the facial plate. It is simply allowing a fulcrum for that specifically engineered roundness of the physics forceps to elevate that tooth up and out of the socket, or luxate the tooth up and out of the socket. So you got to be a little more gentle.
Okay.
And then what I would suggest is, as Kurt mentioned, the courses that we do at the University of Detroit Dental School, you get very proficient when you can take 30, 40 teeth out in that setting. You'll get pretty proficient. There's a learning curve with any new instrument.
Obviously. What about if there's an active infection? Will you graft? Will the chances be significantly less of it being successful? Do you wait a certain period of time? What's your protocol for that?
I curette, try to remove as much of the granulation as possible. If it's purple blood, that's unhealthy blood. Red blood is good. And I have no problem grafting those sites because it will heal. It's just physiologic healing.
Okay, so even if there's active infection, you're still okay grafting those sites?
If there was an abscess there, yes, I would still remove the tooth and graft it. I wouldn't put an implant in right away though.
Right. Why don't you suture the lingual of the envelope flap when you place the implant and leave the bone exposed?
So what I wanted to do is, if I don't have at least 2 millimeters of attached gingiva on the facial aspect of my implant, I need to create it. And it's simply a periodontal technique. So what I'm doing is I'm suturing around that tall healing abutment. So I'm taking that tissue that used to be on the lingual or palatal aspect of the crest, and I moved it to the facial aspect.
Okay. Do you have a favorite needle driver that you like to use?
We all have our favorites. Whatever you feel most comfortable using. There's a lot on the market right now. So.
Okay. I know this wasn't obviously an implant lecture, but what situations would you normally be advising that people use a surgical guide for implant placement?
That's a great question. You need a surgical guide when you need a surgical guide. I think that if you're not sure of the bone contour or the position or the parallelism of your implant, I think a surgical guide is an excellent tool to help you in positioning. To do that, we do our CBCT analysis. A surgical guide is only as good as the person that diagnosed it and made it. And so it's not a panacea. You have to understand that you still have to understand anatomy and understand the contours of the hard tissue. But it's an excellent tool. I probably use a surgical guide 30% of the time. But again, if you're not sure, then I think it's an excellent tool.
Okay. You talked a lot about the need for the attached gingiva. So let's say someone's done an immediate extraction, an implant, there's not enough attached gingiva there, and they don't want to do a connective tissue graft. Is there some type of artificial product that could bring it there, or are they really?
You can, or like at that one case that I showed where I made a mistake and I noticed, I took the impression I didn't have attached gingiva. You can do it secondarily. You don't have to do it all at the same time at the time of surgery. You can do it upon uncovering. But there are allograft materials. I'm not a periodontist, so that's not what my forte is in establishing in growing tissue. If I had that situation, I would probably work with my periodontist to establish better periodontal health.
Yeah, I did perio for 10 years. I love doing connective tissue grafts, but a lot of people don't, so I can understand that.
There you go.
Let's see. Can you elaborate a little bit on the dexamethasone? Do you put it into the site, into the mucobuccal fold? Where are you actually putting that?
Just in the like an infiltration into the mucosa. And in just one site. You know, if you did different parts of the mouth, I would just do one site. And it's a steroid.
When you're
it's better than taking a series of pills, because patients don't take pills, you know, routinely. They
that's true.
fill them and then they save them for another day for some reason. So I inject it and it'll minimize swelling.
When you are trying to cover, say, a buccal defect with a membrane, is the membrane only covering the buccal surface, or do you have it coming onto the occlusal as well?
It has to be passively placed, so I will place it at least 2 millimeters beyond the defect and cover it over the occlusal area onto the palatal area so that it fits passively.
Okay. I know we probably can't go back. Can you just, a couple of people were asking about the name of the suturing book that you had recommended?
It's from Lee Silverstein, Sliverstein, and it was from Salvin Dental.
Don't go to the actual name of the book?
I don't remember. Suturing techniques.
Okay. Yeah, I'm sure you can probably Google Silverstein, Salvo.
Yeah, don't get it.
Suturing,
Amazon.
You'll find it.
It's really expensive on Amazon. It's like $100 book at Salvin Dental.
Okay. You had talked about not using something that's got anything other than a neutral pH. But what about there are some anesthetics out there like Citinest Plain that have a neutral pH. Can that be used with the allografts?
I don't know. I don't know what the literature says on that. All I know is that our lidocaine and our septicane are pH of 2, so I use sterile water or sterile saline.
Okay, and someone had mentioned the name of the book is called The Suture Book, so that's
the
pretty
Suture Book. There you go. Thank you.
Going back to you talked about covering the occlusal surface with a during a graft. If there's also an implant there, are you cutting a hole in the
go right over
membrane?
the top of it. Let's go right over the top of it. It's not going to cover over.
Okay. Someone asking about the CE credits, and those will go out. I mentioned a little bit earlier, but when we have over 700 people that were here live, we have to go through the whole list, and it can oftentimes take a couple of weeks. They do go out. We've never had a case where GoldenDental hasn't got them out, but there's a lot to go through, so be patient on those. The recording will go out sometime in the next 24 to 48 hours, average, usually. Okay, if you're trying to increase keratinized gingiva by moving a buccal flap away from the lingual, what's the maximum amount of distance the new tissue can cover predictably? Like the jumping distance, I guess would be a better way to describe that.
It doesn't matter. The defect can be quite large. I just need 2 millimeters on my facial aspect, so that's what I'm shooting for. There's mucosa on the lingual also. So you have to be focused on that. But epithelium is going to grow 0.5 millimeter to 1 millimeter a day physiologically. So the larger the space, it's just going to take longer to heal.
Okay. We got perhaps time for 1 or 2 more questions. You had mentioned you don't advocate using an osteogen plug if there's a defect on the facial plate. Why would that be? Well,
what we're trying to do here, Lauren, is to do predictability, and we're doing a lot of research on that. And I'm not going to say that I don't do that. I do, but I want to protect it on the facial aspect. So I will use it along with a membrane. The Osteogen plug is really, really, really exceptional when you have all the walls intact. I just want to make sure that what we're teaching here is something that can be reproduced by everybody, all 700 people that listen to us today.
Okay, let me see if I can understand this question here. When you were using the lasso around the healing cap, why wouldn't you just move the tissue buccally prior to placing the healing cap, and do you split the tissue and suture to the periosteum?
No, I do a full thickness. I'm not clear on that question exactly. There's probably different techniques, but what I'm showing is what I predictably do, like all the time. You're going to start noticing lack of attached gingiva in your cases.
Okay.
I mean, you tell me. I'm sure there's lots of different ways of
Oh yeah, a lot of ways
achieving.
to skin those cats. Yep. And what exactly is a periotome? Is it a periosteal elevator?
The periotome is a very, very skinny blade that's used to go between the tooth and the bone to kind of break the periodontal ligament a little bit. I use it to if the facial plate is really thin, I want to see it, but it also allows me to evaluate the anesthesia because I'm just doing infiltration. I'm not blocking the sites.
Got it. Well, I want to be respectful of your time and, of course, everyone who's joined us as well. So anything you'd like to say before we wrap it up for this evening?
Well, I just, God bless everybody and be safe and hopefully our families are safe and this nightmare goes away sooner than later. Thank you, Lauren and Kurt.
My pleasure, and thank you for joining us. I've had the pleasure of hosting you at least, I don't know, 10, 12 times over the last few years. I stay for them. I learn something new every time. Those of you who have been on previous webinars that Tim has hosted, you know that you're not seeing the same content over and over again. It's all new stuff and new cases, and we always have fantastic turnout, and we know your time is valuable and really appreciate that. We also, as I mentioned, thank GoldenDent for their sponsorship. They have just been fantastic to work with over the years. They always bring in top quality speakers. They have great instruments, great return policies, and they stand by what they say. They say what they mean what they say. We've got tons and tons of our clients who use their products, who go to their training courses and just rave about everything. So I would highly recommend taking advantage of the special. Normally, as Kurt said, this special is usually only up until midnight tomorrow, and the fact that they're extending it for 2 weeks really gives you some time to think about things, and you'll have plenty of opportunity to try it out and make sure it's a good fit for your office. We thank all of you for joining us. We know that these are very trying times. We will recover from this. There's no doubt. It's a when, not an if. Hopefully sooner than later. Please stay safe out there. Stay healthy. Take care of your patients as best you can. Take care of your family. Be around your kids. Well, if you're like me and you have a 13-year-old at home, maybe not so much. It's a challenge for everybody, but try to do it with a smile. And we do these webinars on a regular basis. All of you who are here tonight are on the invitation list. You'll get ongoing invitations for future webinars. My expectation is that we're going to be doing significantly more webinars over the next couple of months, just as offices are not being able to be at full strength. So stay tuned. We'll keep those invitations coming. Thank you all for joining us, and we look forward to seeing you all on future webinars. Good night, everyone.
Good night.